Chapter 14. This is the assessment of the medical patient. The last chapter that we covered, 13, was assessment of the trauma patient. There is a significant difference in the way that we assess our medicals versus our traumas. Trauma patients, like I previously mentioned, our assessment is really driven mostly by the examination of the patient. Not that the history isn't important, because the history is definitely important. However, it's less likely to be illness related, so therefore the history is downplayed a little bit. That's not to say that you never have somebody who actually has both medical and a trauma issue at the same time. A lot of times we'll have diabetics or seizure patients who might have a car crash, so now you have a complex situation, and in those situations you combine the elements of both. Obviously you have your objectives in the chapter here on the first couple of pages. Many of them mimic what we saw in the trauma patient, just modified to meet the medical patient's needs. A couple of multimedia videos for you in the non-lectured PowerPoint on physical exam techniques, inspection, palpation, auscultation, and percussion. While percussion is not used at the EMT level, it may be something that's worth at least looking at for a few moments to understand what it is all about. So when you see advanced level providers tapping around on people, you'll kind of get a picture of what's going on. The other video being EMS initial patient assessment, and that will help refresh that a little bit for you. So our core concepts: look at the difference between the assessment procedures for responsive versus unresponsive medical patients, perform secondary assessments for responsive medical patients, tailor a physical exam for the responsive medical patient using a body systems approach, and how to perform a secondary assessment for an unresponsive medical patient. So responsive versus unresponsive. Assessment varies depending on that patient's ability to communicate. This is really critical, because when we're talking to medical patients and trying to do our assessment on them, we focus off of the subjective information that we're given. Sometimes it has to be second party or secondhand subjective information, so we may have to get that from the relatives that can tell us, or the bystanders that can tell us what was going on with the patient prior to their incident. But that's, remember, what drives our medical assessment. When we have an unresponsive medical patient, a lot of times we switch closer to the mode of doing a trauma patient assessment, and just looking for key elements that we expect to be there based off of the limited information that has already been presented to us. So our secondary assessment of our responsive medical patient: obviously history of the present illness and the past medical history, the focused physical exam focused on what they tell us, and our baseline vital signs. To clarify, the first two terms there, history of the present illness and past medical history, are not always the same. In fact, they vary. Sometimes they're very similar based off the patient has really limited past medical history. The history of the present illness may be all that they have. But the history of the present illness is what's going on this time around. Yes, I see you have a history of COPD for the last 10 years. You have a history of diabetes for the last 5 years. But what's going on right now? You got sick yesterday, you're running a fever, and now all of a sudden you have weakness and have had a syncopal episode, which a syncopal episode is the medical term for fainting. So that would be the history of the present illness versus what are your meds, what are your allergies, what are your so on and so forth. So that history of the present illness, obtain this from the patient, obtain it from the family and bystanders, and ask open-ended questions. So we try to get most of our information from the patient, because in most cases they are the most reliable source for information that we're looking for. However, if we have a patient who is not within their right mental faculties, we're still going to talk to them, but we also are going to understand that maybe the stuff we're getting from them is not reliable. Talk to the family and bystanders, regardless of the fact that the patient is or is not mentally competent, we still should ask for observations from the peanut gallery. Sometimes they're pertinent, sometimes they're not. Sometimes we get a completely different story from the people who witnessed what happened than the person who actually thinks they know what happened. And that's a good reason to talk to anybody who was around who saw this, particularly if you have somebody who lost consciousness for a period of time. When you lose consciousness, you may not realize how long you were out. Most of you guys, if you went to take a nap or laid down to go to sleep for the night, if you didn't look at the clock when you went to bed and look at the clock when you got up, you probably really would not have a good understanding of how long were you truly asleep. And the same thing happens to patients with periods of unresponsiveness. Oh, I think I was only out 30 or 60 seconds. Well, there's no way to really judge that without looking at a clock. Now, somebody who witnessed them go unconscious, watched them until you arrived, they can give you a fairly good guesstimation. Asking open-ended questions. Open-ended questions, if you remember, are those that can't be answered with a simple yes, no, true, false. These questions require the patient to give us their answer in really their own words. So those sorts of situations are all going to be, those sorts of questions are going to be based off the situation that we have at hand. So our history of our present illness starts basically with our chief complaint. And this is why the patient activates EMS, or why somebody else activated it for them, and really what is bothering that patient the most. Understand the chief complaint is not always really the biggest problem that's going on. Many times the patient only recognizes a certain sign or symptom, didn't really fully completely understand what else was going on, and other signs or symptoms that they may have had. They may have been unaware. That maybe over time they got used to seeing their, thinking, oh well, my skin is a little off colored, but it's been that way for a while. And then you show up and you notice, oh my goodness, it looks like they've been colored with a yellow highlighter, because that patient is deconditioned. They're desensitized to what's going on. The OPQRST. I mentioned in the trauma assessment that there were ways to kind of look at history of the present illness and history of the signs and symptoms a little more in depth. And here's another mnemonic. So we've gotten lots of those in assessment between our ABCs and our AVPUs and our sample histories and DCAT BTLF, CSM. Well, here's another one for you, OPQRST. We love these in EMS. So OPQRST is a basis, and only a basis, of your clarifying questions regarding a patient's illnesses and their signs and symptoms. This is not the end-all be-all. We'll take probably a very clear example. When we deal with a woman who is in labor, we may be asking all of these questions, but we also want to know, is this your first baby? Oh no, this is my 5th baby. How long did your other labors last? Well, the first one lasted 5 hours and the last one lasted 30 minutes. Well, guess what? You're in labor now. We probably better be ready to deliver that baby if the last one only lasted 30 minutes. So those are additional questions that get thrown into this. But so OPQRST, onset, and I'm going to draw your attention to time. These often will get confused. Onset really isn't a time. It's more actually like event. What were you doing when it started? So the E in sample is very similar to this. Time, on the other hand, is when did it start? But those two get confused a lot. Provocation, or provokes, what makes the pain worse? I like to also put in here the term palliation, which is P-A-L-L-I-A-T-I-O-N. Palliation, that is what makes the pain better. Sometimes moving to a certain position or holding your hand up in the air or whatever helps reduce the pain, and so that's just as equally important as is provocation. So provocation is what makes it worse. Palliation, what makes it better. Quality, describe it. Now, this doesn't fit every sign, symptom, or illness that we come into contact with. But it's really kind of describe your pain or quality, describe the quality of your fever. That doesn't apply. But we can use quality to remind us to ask for more information. Well, can you describe any feelings that you have associated with your shortness of breath? Can you describe any feelings you have associated with your headache? Well, I feel dizzy. So that can sort of kind of be thrown in there with quality. Radiation, and another one I like to add here is referred. Radiation and referred. Where is the pain? Does it seem to spread? And do you have pain anywhere else that doesn't seem to go along with this? An example of this, of referred pain, the probably most common one that we hear of, is people with gallbladder issues. People with gallbladder issues will have referred pain to their right shoulder. Your gallbladder, if you remember, is tucked up inside your liver in your right upper quadrant of your abdomen. Well, it follows a nerve tract, and that nerve tract sometimes tricks you into thinking that it's actually pain in the shoulder. So radiation would be where does it go. So if you were complaining of chest pain, well, I have pain in my chest, but I also feel it up into my jaw and down into my arm. That's radiation. Severity. How bad is the pain? On a 1 to 10 scale or a 0 to 10 scale, I like to use the 0 to 10 scale. If you have 0 is no pain, 10 is the worst possible pain you could ever imagine, rate your scale on your pain on a scale of 0 to 10. People will use 1 to 10, and 1 being extremely small amount of pain, 10 of course being the highest. This can be confusing to people, particularly the elderly. It also does not work well with kids. So sometimes we use something called the Wong-Baker-Faces scale. The Wong-Baker-Faces scale is a series of smiley faces, and if you've been around healthcare for very long, you have probably seen this chart, and maybe even when you were at a doctor's office, you might have seen this chart called the Wong-Baker-Faces scale. And it looks just like that, faces, and going from a big smiley face to a real frowny face. That helps us. We just have the kid, and of course the kid has to be age appropriate for this, but we ask the child to point to the face that they feel like. How bad is your pain? Point to the face that makes us that looks like how much pain you're in. So again, it's subjective. It's not always perfect. It's not always something we can get a good assessment on. When I have problems getting a patient to understand my 0 to 10, 1 to 10 scale, I will often shorten this up and say, okay, how bad is your pain? Do you have little pain, medium pain, or severe pain, a lot of pain? Give them a few less choices, they can better group it. So you can kind of say, well, a little pain would be maybe 1 to 3, a lot of pain would be 7 to 10, so 4 to 6 might be what we refer to moderate pain. So it gives you an idea. Now, pain also is subjective. The amount of pain that one person is in with a broken ankle may not compare to another person. People handle pain differently. And we already touched on time. When did it start? Sample history again. Remember, we covered this in the previous chapter, but sample history, signs and symptoms. So what are we seeing? What are we being told? Allergies to medications, foods, to the environment. Pertinent past history. Remember, we want history that's directly related to what's going on. If we have an 84-year-old grandma who had her appendix out in 1942, we probably don't need to know that unless we're dealing directly with an abdominal pain. So if we're dealing with shortness of breath or something along those lines, that's not terribly pertinent. So sometimes we have to steer our patients. We try to let them talk as much as they can, but we have to sometimes steer those patients in the right direction and say, no, how about anything down the lines of your lungs or your heart or so on and so forth. Last oral intake. So their last oral intake, when and what did they have? And again, I mentioned that this is probably one of the least helpful parts of this, except if that patient is A, going to surgery, or B, has something similar to, say, an altered mental status, diabetic reaction, allergic reaction. Those are some times in which that might be important. Obviously, overdose, but events leading up to the illness. So what was going on prior to all this? And we may have to help dig into that a little bit. Well, I was just sitting at home. Well, how have you felt over the last couple of days? Have you been well? Have you had any injuries? Did you, you're complaining of a headache. Have you fallen in the last week or so? So we sometimes have to use some more detective skills, and that's why I like medical emergencies a lot, is because it's like putting together a puzzle. So tailoring our past history. This important information can be gained by tailoring the history of that patient's chief complaint. Again, this is going back to that grandma with the complaint of abdominal or shortness of breath. Her appendectomy in 1942 probably isn't terribly important to what we're talking about now. So ask questions that are pertinent to the complaint. So this is how sometimes we're going to steer things. So do a body systems approach and focus your questions and examine the particular body systems most likely involved. Don't stall just on one system though, because sometimes there are multiple issues. We might be complaining of shortness of breath, but really truly, why is this patient short of breath? Well, because they actually have a circulatory issue that causes fluid to back up into their ankles and into their lungs. So that's actually a circulatory issue that's showing a sign of shortness of breath, leading us to believe, oh, well, there's a respiratory problem. That's going to be one of the key things you need to pick up on as we venture through the medical emergencies particularly, but even into the trauma emergencies, is what can potentially be associated, what can potentially lead us down this path. Pediatric note, get on the same level with the child. If you're gathering a history, obviously the child will have to be age appropriate. You can't ask a 2-year-old what kind of medications they're on. In fact, there's probably a lot of 9-year-old, 10-year-old, 11-year-olds we can't ask that. So get on that same level with the child. Put your questions into a simple language. Don't baby talk them, but use words that everyone is capable of understanding. And remember that even adults sometimes have a difficult time understanding what we're talking about. And then obviously gathering information from caregivers. That's where the younger the child is, more emphasis has to be placed on the caregivers to give us the concept of what are going on. So performing our focused physical exam, again, this is usually brief. We're going to examine the areas based off their chief complaint, and again, focusing on areas that may also be involved. So if we're complaining of difficulty breathing again, knowing that there are tons and tons and tons of things that can cause difficulty breathing. In fact, that's the #1 call for EMS is difficulty breathing. Knowing that, well, if the cardiovascular system is having an issue, that can cause fluid to back up, and if that fluid starts to back up, then I could see swelling in the ankles. I could have a swollen abdomen. I could have some odd lung sounds. My jugular veins could be distended. So making relations between the different systems will help guide you in that various directions. So as you learn signs and symptoms of the various emergencies, keep those in mind. What kind of sets this apart from other things? What are kind of the special things here that I would need to go looking for if the patient doesn't volunteer it? Obviously, obtaining your baseline vital signs. These are essential to the assessment of your medical patient. They're essential to most of our patients. Later assessments of vital signs will be compared. Remember, this is called trending. So that baseline vital signs, those are the ones we want to be really accurate, if at all possible. Preferably not done by a machine, preferably done by a person to get the most accurate reading. And so that requires you to be proficient. So where would you focus your physical exam on a patient complaining of shortness of breath? Again, mostly this is a chest issue, but we also know that there are potential other places to go down the road. And I'm not going to dwell on these because I've talked about them, and we're going to learn more about them as we get to the medical emergencies. So, but mostly we concentrate on the chest and maybe in the neck area. So to move to an unresponsive medical patient, we have no ability to communicate with our patient, and that's going to shift our focus from their chief complaint to their history taking, or from their chief complaint and history taking to the physical exam. The chief complaint of an unresponsive person is unresponsive. You can have unresponsive, altered mental status, or what the patient tells you. That's your chief complaints. So begin with physical exam, baseline vitals, gather the history from your patient bystanders, and then do a rapid assessment of the entire body. This needs to mimic our rapid trauma assessment that we did, a rapid trauma exam we did on our trauma patients, because they can't tell us, look at my hands, look at my feet, look at my abdomen. All we have to go off of is what we can gather from the scene, from the bystanders, and, and possibly from our history with this patient. So doing a rapid check the head, check the neck, check the chest, check the abdomen, pelvis, genitalia as appropriate, extremities, both upper and lower, and the posterior or the back. A quick overview to let us see, is there anything jumping off the page waving a red flag at us, say, hey, look at me, look at me. And that's the purpose of that, is we don't have the other information, we have to gather it. That's exactly what I just said. So, important physical findings for medical patients. In the neck, we're looking for JVD. That's jugular venous distension. Remember, that's those big veins that come down, basically straight down from your earlobes and meet up with your shoulders. Those are distended in patients with increased pressure in their chest, whether that's from their lungs or from their heart. Increased pressures in the chest cause JVD. The best way to assess that, the patient's laying at a 45-degree angle, and in most cases you won't see the veins stick up more than halfway up their neck. If it goes all the way up to the crook of their jaw, they have JVD. Medical identification devices. Do they have a medic alert bracelet, or not, it wouldn't be a bracelet, be a necklace on their neck? Remember, if you're going to have to put a C-collar on this patient because you just don't know, then remember to remove that first. Some interesting information on medical ID. There are now electronic medical record holding places that you can compare a person's medical ID with something online. And if it's something that gets used in your community, you can log on via your smartphone or your computer that's in the truck, iPad, what have you, put the patient's medical ID number into your device, and it will populate with usually a picture of the patient and then the pertinent medical history that goes along with it. Most of the time people wear those medical identification devices, medical alert bracelets, whatnot, have a condition that they could be rendered incapable of giving you the information you're looking for. Chest, we're listening to breath sounds. Abdomen, we're looking for distension, whether it's firm or rigid, or whether they tense up a lot when you push on it. Pelvis, we're looking for incontinence of urine or feces. There's a possibility you could see a priapism in a medical patient, particularly some patients take erectile dysfunction drugs. Extremities, we're looking for pulses, motor function, sensation. You can check oxygen saturation, medical identification devices, swelling, or what we call edema. So determine whether ALS is required. If you have an unresponsive medical patient, ALS is required. So if the patient is unresponsive, the patient is unstable, and you have the capability of getting paramedics or EMTs on the way, get them on the way. Because if it's something very simple to fix, like a diabetic reaction with an extremely low sugar, that's something that can be done with an IV. where the patient is unable to swallow because they're unresponsive, a quick IV and some sugar down the IV actually can turn this from a potentially dangerous situation into a no problem, really. So bystander questions. What's the patient's name? What happened? Did you see anything else that happened? Did the patient complain of anything before this happened? Does the patient have any illnesses or medical problems? You can get the sample from them many times. So allergies, medications, pertinent past medical history, any history of the present illness maybe, by saying, well, what do you know about the patient? Have they had any recent surgeries, any recent falls, any, so on and so forth, depending on what you're seeing. So what other mechanisms might you have to obtain a patient history other than speaking to bystanders? And again, like I mentioned, Medic Alert, there's different options out there now. They're smart options. Vial of Life. The Vial of Life is often something placed in or around the fridge that has a list of the patient's medical issues, as well as their medications, allergies, so on and so forth. Sometimes people will carry these in their purse or their wallet. I think more and more we're starting to see people with smartphones that may have this information in there as well. So we have alternatives. There's a video regarding physical exam. So comparing our assessments. The responsive medical. Primary assessment, it's the same basically in everybody. We can really tailor that in the conscious and alert patient, as they really, in many cases, we walk in the room, we're talking to the patient, they appear to be in no acute distress, and we know that everything in their primary assessment is, at least to start, probably going to be okay. If the patient is alert and there's no life-threatening problems, we do a secondary assessment on them. We're going to modify our exam, do a history of their present illness and that past medical history, get the vital signs, and then begin transport. The unresponsive adult medical patient, on the other hand, primary assessment, that patient's not alert. Those ABCs can and probably are compromised. We work on fixing those before we move forward. Rapid physical exam, because we need to do that quick once over head to toe because we can't get the specific info from the patient. Vital signs, past medical history and history of the present illness from any bystander, family, so on and so forth. Transport, and then prepare to do a detailed exam en route. Again, like we did in the trauma patient, if we have the time and we have the hands and everything else is under control, we will do a detailed assessment on an unresponsive patient, simply to gather the most information possible. So you have a video, our chapter review. History and physical exam of the medical patient takes two forms depending on the patient's level of consciousness. You assess the responsive patient by getting the history of the present illness and the past medical history, doing a quick focused exam on the parts that they're telling you, and then getting your vital signs. Unresponsive medical patients, they can't give you that information, so we switch focus a little bit to a rapid physical exam, get information from anybody on scene that we can, vital signs, and then get trucking. You may not change any field treatment as a result of the information gathered here, but the results of the assessment can be very important to emergency department staff. There's a lot of things in EMS that we have no control over, we can't do anything about. We don't have all of the luxuries of a hospital at our disposal, nor do we have the appropriate training to do all this. So, but if we can gather a specific piece of information in the field, it may be that key piece of that puzzle that they need in the ER to get this patient treated. All right, determine if your patient's is responsive and alert and reliable enough to get information from. And if they cannot provide you that history, see who's on scene that can, or go hunting for scene clues. Consider what kind of a history and physical exam that patient's chief complaint suggests. Do we do the quick exam route with some follow-up questions to the bystanders, or do we focus it mostly on patient. So explain how and why the history and physical exam for a medical patient differs from the history and physical exam of a trauma patient. Explain how and why the history and physical exam for a responsive medical patient differs from that of an unresponsive medical patient. And your critical thinking question is, you're trying to get information from a very upset son on an unresponsive man. He is the only available family member, and he is so upset that he's having difficulty talking to you. How can you quickly get him to calm down and give you his father's medical history? Well, in many cases, if you shift some of this responsibility to them, you shift some of this burden to them to say, look, I can't appropriately treat your father if I don't get specific and detailed information. That puts a sense of urgency back onto that family member, and they may decide, okay, I have to be able to pull myself together and do this. Otherwise, my father's life could be in peril. And that wraps up this chapter.